All right, so let's go ahead and get started. And what I did was I broke up the talk into separate sections. So like our poster said, these are some of the questions that my patients ask all the time. So how does the heart work? Starting as at the basics, lifestyle choices that affect how the heart works. And the biggest one is, why do I have to take all these medications? I thought I could just take one medication and my heart would be great. So I think if some of you have cardiac disease or have family members that have cardiac disease, you probably notice a lot of medications on their med list. So we're going to talk a little bit about why we use multimodal effects or multimodal kind of approaches to medications and why we do that. All right, here. So the first thing I'd like to talk about a little bit is, how does the heart work? So I picked the top 4 kind of categories of things to talk about tonight. The first is electricity. The second is blood flow and valves. The third are some of the hormones that we're going to talk about, and this is really where those medications come in. And then also some minerals and electrolytes that we talk about quite frequently that help our heart function to its highest capacity, or the best that it can be. So I always like to start with electricity. So this is a picture of, I'm going to do a little pathophysiology here, and then we'll move from one picture to the next. So when we're born, we all are born with the natural pacemaker called the SA node, or the sinoatrial node. And as you can see here in the picture of the heart, we have 2 atriums, which are the top part of the heart, and then 2 ventricles, which are really our workhorses, or our big muscles of the heart that pump the blood out into our system, especially the left ventricle. That's the big working heart muscle. So the SA node is a natural pacemaker. So it is telling your body to beat at a certain rate. And we're going to talk a little bit about how that SA node gets a little excited sometimes and why that is. So if we look at the electrical kind of current of the heart, the pacemaker takes a kick or starts that initial heartbeat. And that SA node then travels to the atrial node, which tells these 2 atriums to contract. Then at the same time, that electrical current is coming down here. These are called the Purkinje fibers. And these are like little electrical wires. And they are, this big thing here is called the bundle of His, but we have the right bundle branch here. And we have the left bundle branch here. And there's also one that comes down in the middle. But on this picture, it's just showing the 2 bundles. And these electrical wires are sending this SA node to the AV node, to these electrical wires, and telling the ventricles to contract. So that's what you're seeing down here on this second picture. So you can see up here, the SA node is talking to the atrial node. They're firing down the Purkinje fibers into the left bundle and into the right bundle. And it's telling this heart to contract from top to bottom. So that's usually where I like to start, with just a little pathophysiology of the heart. This is another look at how the electrical current of the heart, and what we look at as providers, whether you're a primary care provider or a cardiologist or a specialist or surgery, but we're all taught how to read EKGs and what does that mean when the heart is beating. So, excuse me, as you can see again here, this is your sinus node into your atrial node, following the Purkinje fibers. And each one of these is a certain part of this EKG right here. So as it beats, it's giving us this pattern, which if you've had an EKG before, it may look similar. This is a normal beat on an EKG. And this is how the heart is following that EKG pattern. So each one of these little bumps and means something to us as a provider. So for example, this P wave is the start of the SA and the atrial node contraction. Then we get this big R wave. And some of you, if you've had a heart attack or know somebody who's had a heart attack, this ST or non-STEMI or STEMI you've heard of, for myocardial infarction, this right here is the left ventricle. And so when you have a heart attack and we can't get blood here, that you can tell that this muscle won't pump as hard. So we'll either have a big tent up in here, or we may have it coming sloping down this way. So when we talk about looking at an EKG, this is what we're looking at, how the electricity is flowing through the heart and what this EKG means. And each one of those little sections can diagnose different types of arrhythmias or different types of heart rates. And we won't get too much into that tonight, but I like this picture side by side because it looks at how the electricity moves through here and what we're looking at on an EKG. All right, so the next part of the pathophysiology that I want to just talk about, because I think a lot of us have heard about mitral or tricuspid regurgitation, and we see this with congestive heart failure. And this is really what the valves look like in the heart, just from an animated picture. So from the right atrium, we have this tricuspid valve. And in all of your valves, it doesn't matter if they're in your arms where they're starting IVs, or they're in your legs and you have varicose veins, all of those valves are supposed to push blood through, but then they're supposed to snap shut tight so that the blood doesn't leak back down into so it doesn't leak back and forth here. So you can imagine with leaky valves, that makes your heart work harder. And then all of the blood can't get pumped back up because some of it is leaking back up into where it's not supposed to be. So these valves are really important when we're talking about the health of the heart. And sometimes they're damaged by cholesterol plaques that break off. Sometimes they're damaged by, you've heard of rheumatic fever. That attacks some of the valves. So there's all different kinds of reasons why those valves get leaky. But the number one reason is old age. So just as all of our other organs kind of wear out, I mean, short of a traumatic event to the valve, they just run out of steam. So they'll start to leak as we all get a little bit older. All right, then one more final picture of our valves. I know some of you probably had an echocardiogram in the past, which is an ultrasound of your heart. And just as the EKG is giving us information about the electrical properties of your heart, the electrocardiogram is telling us how these valves are working and also the strength of the ventricles and how well they're pumping that blood out. How strong are they? And then they're also measuring, as you can see here, the left ventricle. This is that bicuspid valve, mitral valve. And it's also, we do a measurement on the width, or how wide the wall is of the ventricle. We'll talk about that a little bit later when we talk about hypertension. And these colors are measuring pressures in the left ventricle for us. And that tells the cardiologist when they're reading it, there's a certain normal value for pressures, and these colors mean something to whoever's reading this. But on echocardiogram, this is what that tricuspid valve works like. And you can see it opens easy, but it snaps shut. So there's no leaking in this valve. All right, so the next thing I want to move on to, and then I'll just take a break for a few questions here in just a minute, is while we're talking about the electrical, now we've talked about the electrical pieces, or current of the heart. And we've also talked about the muscle part of the heart. So we look at EKGs and we look at echocardiograms. And together they tell us a story about how well your heart is functioning. So let's say, for example, you go into your primary care doctor's office and you say, boy, I'm really more short of breath and I don't know why I'm so tired. And sometimes I get these little pains in my chest and I don't know if it's gas or if it's really my heart. And they say, well, I'm going to order a stress test. And there's, so I want to review the 3 different kinds of stress tests and why we order what we order, and what information that gives us. So if you've had a stress test, you'll notice this is what a stress test lab looks like. We have a blood pressure cuff on your arm. You have 12 stickies on your chest. and your abdomen that are looking at different pictures of your heart, and part of that electrical current we're measuring in a 12-lead echo or EKG. This is the EKG machine. So this will be what we're looking at as we're observing the stress test. So this gentleman here, when we order a treadmill or a treadmill with nuclear medication, and I'll talk about that in a minute, we exercise everyone using a protocol. It's called the Bruce protocol, and it's been tested for 100 years or so. But what it does is it gives us some guidelines. So we monitor, we get a baseline EKG to look at your electrocardiogram and all of those waveforms to make sure we know what your normal electrical current is in your heart. And then we start you out at a very slow pace. It's actually kind of awkward. It's halfway between a walk and a run. And then every 3 minutes, that treadmill is going to go up and it's going to get faster, because the goal of the treadmill is to make your heart work at 85% of what your target heart rate should be. And so if you want to calculate your target heart rate, it's 220 minus your age times 0.85. And that will tell you what the goal is, that what we're shooting for when we have you in the stress lab. So a reason to order just a plain old treadmill is really to find out what your exercise tolerance is. It also measures what are called METs, and it measures how well the oxygen in your heart is being used. And we want to get you to 7 METs or higher. And that's telling us that your oxygen is being used effectively in your heart. So for just the basic treadmill, we see a lot of athletes, young athletes that really maybe they're having heart rates of 200 or 220, and they're running track or they're playing football or something like that. We want to see what their heart rate does just on a treadmill, and see if we can make their heart rate go above their target heart rate, and see how they tolerate that. A better test for people of average age, I'm not talking about super athletes or our young patient population, is really a treadmill with nuclear medicine. And some of you may have heard this called a treadmill with Cardiolite. So it's the same setup that you see here. We start out the same way, but once you get to your target heart rate, we inject you with a nuclear medicine called Cardiolite. And what that does is that circulates in your heart, so that when we take pictures after your stress test, we can see a lot of different things. We can see how the left ventricle is working. We can see the thickness of the wall of the left ventricle in those pictures. We can see if your valves are leaking. So this is really a tracer. It's kind of like injecting, I always say, like glitter or sparkly glue into your arteries, so that it'll show up on a picture for us. The treadmill with nuclear medicine, I forgot to say that we take pictures prior to, we put you on the treadmill, we give you the Cardiolite, and then 45 minutes after you've recovered, we take a second set of pictures. So the before and after is what the cardiologist is looking at when he's reading your test. Then the last stress test that we do, there's another one, but we don't do it very often. It's called a stress echo, where you're doing a stress test and an echocardiogram at the same time. And there's a certain diagnosis that we're looking for that. So the third test is called a Lexi scan. And this test is reserved for people who cannot walk on the treadmill. So you may have poor mobility, you may have, a total knee or a hip, or just you're very deconditioned. You may be post heart attack and just don't have the stamina to be on the treadmill for 7 to 10 minutes. And basically what we're doing is we are giving you a medicine called regadenoson, that's the generic name, but the other brand name is called Lexiscan. And that drug is vasodilating your heart muscles so that we're making them, we're making your heart rate go up, we're making your blood pressure go up. So this is a test, again, that will mimic that treadmill with nuclear medicine. The way that we start this is we get a baseline EKG. The nuclear tech comes in, they inject the Lexis scan, and then right away they inject the tracer, the Cardiolite tracer, because this particular stress test has pictures before and after also. The one thing about the Lexi scan is that the side effects of the drug, it only lasts for a minute in your system. And usually about 10 to 15 seconds after the injection, people will complain of lightheadedness, dizziness. They may get a little sweaty, nausea. Some of my patients will say they feel like they're coming down a roller coaster, and some of our patients don't have any symptoms. So we kind of walk you through that and what's going on and just kind of help you breathe. We have you pump your legs so it moves the medication through your system. But the whole thing takes about 3 minutes for a LexiScan. Now, the reversal agent for LexiScan is caffeine. So the first thing we do as soon as we are done getting the pictures or the EKG that we need in the stress room is we give you some caffeine. So if you're at the hospital, you're going to get some awesome Highland Grog coffee, or you're going to get some Shasta soda. But we give that to you right away so that the side effects that you're having will leave your system within about, again, another minute or two. And like I said, then we let you recover for about 45 minutes and walk you to a rest room around the corner, and then they come and get you for your pictures. The only people we worry about with the LexiScan and the, I can never say it, LexiScan drug is people who are prone to asthma or severe COPD, because this drug can make that worse. And if that happens in the stress lab, the first thing we do is give you caffeine so that we will start the reversal process. And then if we're still having trouble and you're still not breathing like we want you to breathe, then we give you some aminophylline IV, which is a very common drug to reverse asthma. So just to review, we can do we do 4 different kinds, but these are the 3 that we usually do. Just a regular treadmill that's looking at exercise tolerance. Treadmill with nuclear medicine, this really pushes your heart to be above that 85% of your target heart rate. So we can see what it's doing electrically, and then on the pictures, what your muscle is doing. And then the LexiScan is reserved for people who cannot walk on the treadmill. All right, so I'm going to stop here, Gadir, and just see if there are any questions about electricity and blood flow.
You either can unmute your microphone, or you are welcome also to put the question in the chat.
Okay, Gadir, I'm going to keep moving, and then if something comes up, you just, oh, there's a chat right there.
I have a question.
Okay.
When you talk about electricity, is it the same kind of electricity we talk about in a light bulb? I'm trying to, no. See, I'm trying to figure this out.
So we use the word electricity, but it's because it is stimulating the heart to beat. Like if you flipped, I suppose if you like flipped a light switch, but it's not, I don't, let's see, how do I explain this? It's an electrical impulse that is created from the cells in your heart.
Okay.
Does that make sense?
Yes.
Okay. So every cell in your heart could be that SA node. It can stimulate an impulse to make that heart beat.
Oh, there you go.
Oh, I'm sorry, go ahead.
I say, okay, there we go. I just got it. Yeah.
Okay. However, you can imagine if every single cell in the heart was firing at one time, it wouldn't be very coordinated movement. So God gave us this SA node to kind of be the, what do you want to call it? Like the conductor of the orchestra. So we like all of the first impulses, or those impulses to come from the SA node. However, in other talks that we will be giving, sometimes that SA node, it gets sick itself. So you've heard of atrial fibrillation?
Yes.
That means that the atrium is not listening to that SA node that's firing all over the place. The SA node's firing, the AV node is firing, and they're irregular beats. So sometimes that SA node and the AV node are not talking to each other very well. But that'll be another talk unless we have time at the end.
Okay, thank you.
You bet, absolutely.
Dr. DeGroot, I do have a question in the chat. It said, does the outside temperature affect the blood flow? For example, if it's cold?
It will affect the blood flow, but you would have to be very, very cold. So what the cold temperature does is vasoconstrict all of your arteries. So your blood pressure will go up and your heart has to work harder. So yes, if you are outside and you are, stuck in the snow and you are hypothermic, then yes, this will cause a significant stress on your heart. And eventually your heart will just stop because the arteries are so constricted because it's so cold, it can't get blood to the heart. Does that answer the question?
Yes.
One more.
It said yes, this is answer the question, yes.
Perfect. Okay, so then I'm going to just move on. Got to that. All right, so the next thing I want to talk about, again, this is very simplistic. So minerals and electrolytes are a very complex part of what make all of our arteries function and all of our organs function. But the main ones we're concerned about when we're looking at cardiac health, and some of you have had lab work called a basic metabolic panel. And what we're looking at in that panel are these minerals and electrolytes, but also looking at how your kidneys are functioning. So for example, potassium helps keep your heart beating at the right pace. So it's just an easy way to kind of remember potassium. If you're too high potassium, you have very deadly arrhythmias in your heart. The electricity doesn't pump like it should be in a nice normal rhythm. If you have too low of potassium, the same thing happens. So potassium is really key to helping that heart beat at the right pace. Sodium plays a role. This is a very complex role in our body. It's really a healthy function of nerves and muscles and helps keep your body fluids level and proper balance. So one of the things that I teach my nursing students is that water follows sodium. So if you have a big sodium influx, say for a meal, you'll notice in the next morning that your hands and your feet or other parts of your body are swollen because you're retaining fluid. That's because you have had a big sodium load, and water follows sodium. We'll talk a little bit more about that when we talk about the medications that we use. Magnesium, it properly times the gates of your AV node. So it helps with spasticity. It also has some effects of the electricity, but mostly it's in the timing between the SA node and the AV node, that kind of talking part. And then calcium, and you can remember this, it really helps the cells in the heart squeeze together or contract, which makes the heart pump blood. And when we talk about the medications, we talk about calcium channel blockers, those, again, coming up, that is, we're trying to block some of the effectiveness of those contractions of the heart. So I have that coming up in just a little bit. And we'll circle back to some of these minerals and electrolytes as we move through the talk. But these are the four main minerals and electrolytes that we look at as providers when we measure your blood. All right. All right, so now on to the lifestyle management piece of it. So this is the piece that I probably spend most of my day talking about with my patients. So I work with Dr. Kaji, he's my cardiology partner. And a lot of what his brain does is talk about all of this stuff, pathophysiology, what did your echo show? What does your EKG show? And this is really where, I mean, not only do I talk about that other stuff on follow-up with patients, but this is really where I spend the majority of my time, because we're going to talk a little bit about, can I just do one lifestyle management? Can I just do pharmacology, or do I need to do both? And the answer is you need to do both. So we always start with lifestyle management. We give you about 3 months to see if we can turn it around. And if you still have high blood pressure, which we're going to talk about, then we have to talk about medications. So the first thing we talk about, I spend a lot of time on, is diet and salt. So what we want for a healthy, but what the research shows is that we should be eating less than 2,000 milligrams a day of salt or sodium. And I have a label that I'm going to show you about, which is really about a teaspoon of sodium a day. Teaspoon of sodium combined over 24 hours. Our weight plays a big part in hypertension and how hard our heart has to pump to get blood through. So your body mass index, your doctors are talking to you this, I'm hoping all the time, should be less than 25. And most of our patients laugh out loud in the room and they say, I haven't had a body mass index of 25 since I was 14, or I was in high school and I was a wrestler. And you know what? They're right. So anything above 25 to about 35 will automatically start putting more stress on your heart, because we have to carry around that extra weight. And then also for our stress test, if you have a BMI above 34, we have to do a 2-day stress test, because that cardiolite tracer is absorbed by fat. So you have to come in one day, get the tracer in your pictures, and then come back the next day and do the second part and get another, put you on the treadmill and get another tracer, because it will be metabolized. It's metabolized in the fat tissue. So BMI of 25. If you want to know how to calculate your BMI, you can just Google BMI on any browser that you want. You type in your height and your weight, and it will tell you what your BMI is. All right, sleep apnea or snoring. This puts your heart under a significant amount of stress. So I like the way that Dr. Kaji explains it to our patients is, we have these muscles right in here. So when we're young, they're nice and strong and tight, so that when we lay flat, we don't have any trouble where we stop breathing. Those muscles don't collapse onto our airway, because collapsing onto the airway causes sleep apnea, which means we have pauses in our sleep while we're sleeping, and or we snore. So think about it this way. You need your respiratory system to carry oxygenated blood to the heart. And if your muscles are collapsing because of age, it's really truly because of age, unless you had a trauma effect, and you're cutting off the oxygen that can't get to your heart, what's your heart going to do? It needs to work harder. It's being kind of starved of oxygen for short periods of time, which puts stress on the heart. So snoring, if your partner snores or someone in your house snores, that's the first thing you should do, is ask your primary care physician for a sleep study. And that they will be able to diagnose, is that snoring? Is it sleep apnea? Is it something we can change with a mouthpiece? And as we lose weight around here, around our necks, we also measure neck circumference in people. Large neck circumferences will lead to sleep apnea. Then as you lose weight, and we lose weight around our neck, sometimes the snoring goes away as well as the sleep apnea. But I don't see that a lot in our patients by the time they get to cardiology, but that's why your primary care doctor is asking you all those questions. All right, diabetes, we want to limit carbohydrates. Why is diabetes something that we want to keep under control? Those of you who have diabetes, you know that the blood lab test is called a hemoglobin A1C, and it's measuring your blood glucoses over time, as opposed to getting just a blood sugar check every day. And we want to be less than 7, because once we get above 7, that diabetes is affecting our arteries in our body everywhere. So diabetes, because of high blood sugars over time, they affect start with the small vessels in the toes and the fingers. We say people with diabetes can't feel their feet. It's because those nerves are damaged from the high blood sugars. As you as the diabetes progresses, it will eventually attack the larger blood vessels like the aorta, some of the vessels that feed the kidneys, feed your legs, but primarily it starts out in the small vessels. So we want to limit our carbohydrates. So donuts and pasta and rice and bread and all of that stuff converts to sugar by our liver. So we don't want to do no carbohydrates. You can, but I hate to put people on strict diets like that because it's not a long-term solution, but rather to balance your carbohydrates with good Mediterranean fishes and oils and chicken and that kind of stuff. And then the last thing that is really heart healthy is we want to be able to exercise for 30 minutes a day. And what the research shows is that it doesn't matter if you exercise 30 minutes straight, or if you exercise 10, 10, 10, or 5 times 6 times, as long as you get in 30 minutes a day and you're able to raise your heart rate so that you're just a little bit short of breath. So when you're exercising or you're out for your walk or you're walking the dog, you should be breathing like, we're not interested in cardio, the high intensity exercise. If you want to do that, that's fantastic, but there's no difference in your heart health. We just need you to exercise till you're a little bit short of breath for 30 minutes a day. And that is what the research supports for having a heart healthy, or for having healthy, how do I say this? To be healthy related to your heart and your blood pressure. All right, I'm just going to see what my next slide is before we start. Okay, this is the nutrition label that you spend a lot of time with in our clinic talking with people about. So you can see here that the sodium in whatever this was, I think it was, I don't remember what this was, for 1 cup of whatever this is, your sodium is going to be 240 milligrams. Remember, you only get 2,000 milligrams a day. So if you eat this whole serving right here, again, whatever that was, you've already taken up almost 1/4 of your allowable sodium for the day. So when you're at the grocery store, flip the container over. First, see how much there is. This is about 10%, but you can see some are 40s and 50s, like, frozen foods and stuff that comes in a can. Some soups are up into the 25 or 30% of sodium because that's why they taste so good. So we just want to make sure that we're looking at the servings per container, and that will tell you how much sodium you're eating. All right, so I'm going to stop there, Gadir, again. And I see there's a question in the chat, and then we'll talk about hypertension and blood pressure.
Thank you. One of the questions, it said, are these elements all positive charge? I'm sorry, it's moved.
Oh, positive charge? I think so.
Yes, I recall the potassium K is 1, but I'm wondering about the others.
Yep, sodium, calcium, and magnesium. Yes, they're all positively charged.
And then the label implies that recommended daily allowance is 2,400 milligram rather than 2,000. Just an observation.
It is. I would agree with you 100%. But what we look at from a cardiology perspective is the research will say that 2,000 is really our target. I mean, you have to remember our clientele are people with typically with heart damage or heart disease already. So we need to keep them a little bit low on the lower side. But yes, I've even seen 2,500 as the average daily, as long as you don't have hypertension, high cholesterol, diabetes, and heart disease. So if you have none of those, I've seen even as high as 25. So thank you for that. I appreciate that. I have my cardiology lens on tonight, so I appreciate that feedback. All right, let's talk a little bit about hypertension or high blood pressure. And I love this picture because how many of us go in and we have what we call white coat syndrome right here, right? It says, I'm going to take your blood pressure, so try to relax and do not think about what a high blood pressure reading might mean for your chances of living a long, healthy life. So oftentimes what you'll see in physicians' offices or advanced practice providers' offices is patients will say, man, that's really high today. I have white coat syndrome. That's really, really high for me today. And most of us will say, I hear you. Let's collect some data. Whether we send you home to do some self-monitoring of blood pressures, because the last thing we want to do is start treating one high blood pressure reading. So the research would say that in a physician's office or a provider's office, you need to consistently have 3 blood pressures over time. Maybe you come in 3 times a year, or you have your wellness check, and then you have at another specialist office and they take your blood pressure. 3 readings over 130/80, which are the new 2017, which are kind of not new anymore, guidelines. So we're going to talk just a little bit about hypertension, because this is key to maintaining a healthy heart. All right, high blood pressure. So a couple slides here. So high blood pressure is a sign that the heart and the blood vessels are being overworked. So untreated, the disease can lead to atherosclerosis and congestive heart failure. And we're going to talk a little bit about, I think we talked a little bit about this. So the harder that this left ventricle has to work to pump that blood up through this valve and out into the system, takes its toll on the left ventricle. So it gets stiff. The heart muscle gets stiff. And as it gets stiff, it can't pump out as much blood as we want it to. So that blood backs up into this left ventricle, causing enlarged heart or heart failure. So this would be left-sided heart failure. Heart disease contributes to about 75% of all heart attacks and strokes. We're going to talk briefly just about cholesterol and atherosclerosis coming up, but this is just a picture of what that plaque looks like. This is really how arteries get plugged, whether it's a heart artery, a head artery, or a neck artery, but it's the cholesterol that's being laid down. And high blood pressure is a #1 reason, besides smoking, that people start laying down cholesterol or plaque into their arteries. So I like this picture a lot, because what it shows is high blood pressure not only affects the arteries in the heart, but it affects all of the arteries. So it affects the arteries that feed that are up in the brain. So it can cause dementia over time. It can cause a clot in the neck, which would lead, a piece of that breaks off into these carotid arteries right here. It will lead to the brain and cause a stroke. Here we talked again about it, the enlarged, I just got to move my little panel here, enlarged heart or heart failure. If it's completely blocks off one of the arteries in the heart, you'll have a heart attack. Kidneys also have arteries to maintain. We're going to talk a little bit about the hormones here, but the kidney arteries really are essential to pumping out the water and the sodium and maintaining a healthy balance. The kidneys do a lot of work on a very complex system for regulating blood pressure. You can have enlarged arteries, which can weaken the wall over time. So you can have an abdominal aortic aneurysm, which is right about your belly button. You can also have a thoracic aneurysm up here. So the strain of that constant high blood pressure on that artery will cause a weakening in the wall. So instead of having an artery that's straight, when we do a CAT scan or an ultrasound, your artery coming down off your heart, say underneath your belly button, is going to start to look like this. And that means that wall is weakening, and you have an aneurysm there, a weakening of the wall. And you can also have blocked arteries into your legs. So if you are walking, we call it claudication, and you have blockages in these arteries that are right below this bifurcation, no, right above the bifurcation. These are iliac arteries. You're going to get butt pain when you walk. If some blockages are in this big artery here, you're going to have thigh pain when you walk. And there's 3 arteries below the legs. You may have calf pain when you walk. So that's kind of why we ask some of those questions when you come in to see if you're having claudication type symptoms. All right, cholesterol. This is my favorite hamburger day. It's my favorite day of the week, or well, I really should say month or 3 months, because I shouldn't be eating a lot of these. So we talk about cholesterol. We talk about all those high fatty foods that lead to this, and I love this picture too, it leads to that clogging of the artery that I showed in a couple slides back. So one of the ways to think about and visualize what does cholesterol do and why does it make me have high blood pressure is if you take a hose, just a water hose, and you just turn it on without your thumb over it, the blood flows evenly, right? Or the water flows evenly. It's nice and smooth. There's no tension on it. But as soon as you put your thumb, imagine that thumb is that cholesterol blocking that artery. Look what happens here. The pressure of the water gets higher. It shoots farther, but it also has to work harder. So this is what's happening in your heart. When it's going through a smaller than average diameter, you're trying to get the same amount of blood flow through a very much narrower artery. So your heart has to work harder. So your blood pressure is going to go up. All right. So before we go to medications, I see there's another question in the chat room, Kadir. See if I can see that. This says, what if only one of the systolic/diastolic is too high? Is this within the bounds of hypertension? So we really look at the systolic number more than the diastolic number. If you have high diastolic pressures, most of the time you have some sort of heart disease, like heart failure, or some sort of heart disease. So we really treat off the systolic, and primary care also treats off the systolic number. So if you're above 130/80 consistently, according to the AHA 2017 guidelines, then like 136 to 145 is considered stage 1 heart blood pressure, hypertension. So we would, for example, give you 3 months to work on lifestyle management. And if you're still having consistent numbers above 130, then we would have the first conversation about adding medications to that. So I'm hoping that answers the question. And if it doesn't, we can certainly come back to that. All right. Gonna get out of here. Great. All right. So let's see if we can kind of pull some of this together here with medications. So like I had said, you know, the American Heart Association used to have their 2010 guidelines said, treat people 140/80. And we would do the same thing. If you would come in and be consistent 140/80 or higher, we'd give you 3 months to talk about lifestyle management. If we still weren't successful with weight loss and looking at sodium and monitoring your diabetes, then we would say we need to start talking about medications. The reason that the AHA dropped that blood pressure is because we use it as a screening tool. So by dropping the blood pressure to 130/80, we're finding more people earlier, and we're starting those lifestyle management pieces earlier to hopefully avoid medications until we get into our older ages. So that was the primary reason for lowering that number. And we also found that people did better long-term if we needed to start pharmacological management to keep the blood pressure less than 130/80. Long-term effects of blood pressure in the kidneys and the liver and all of your other arteries, long-term into our 70s, 80s, and 90s, we had better outcomes and less complications of heart attack and stroke. So that was the reason for dropping the recommendations for treatment. All right, so we talked a little bit about calcium. I'm going to start down at the bottom. So calcium channel blockers, remember, calcium talks about contraction, right? It's supposed to be helping the heart contract. And I have some notes too that I'm just going to take a look at here. So it works on the lining of the blood vessels. So if you're being put on a calcium channel blocker, this used to be a go-to for blood pressure. It is not so much anymore as a place where we just start, because the ACE inhibitors and the angiotensin receptor blockers, or ARBs, are better drugs. but these are the drugs that end in pines. So like amlodipine. That would be an example of a calcium channel blocker. So if calcium causes increased contraction in the musculature of the blood vessels, if we give you a calcium channel blocker, it's going to relax the blood vessels. It's not going to make it contract as hard. So it works very well as a blood pressure medication. Let's go up to the beta blockers. So the beta blockers, again, very common drug that we prescribe sometimes right out of the gate. These are metoprolol or carvedilol. Those OLOL drugs, those beta blockers actually reduce the blood pressure. They actually reduce a hormone called aldosterone, and aldosterone is made by the adrenal glands. So as the adrenal glands are kicking out this hormone called aldosterone, doesn't mean that it's abnormal, your adrenal glands, it just means it's kicking out a lot of this hormone. The heart is saying it's kicking out a lot of this hormone, so I need to work harder, right? So if we block that with the drugs called beta blockers, we're blocking adrenaline and therefore reducing the blood pressure. So I always like to think of this drug, you've heard of fight or flight, or when we get scared, that kicks off adrenaline, kicks off the adrenal glands, and it produces adrenaline. So your heart's beating really hard, you get really sweaty, you feel that feeling. Well, that's what's happening when people are kicking off this adrenaline hormone. And again, you don't feel like your heart's jumping out of your chest. But again, it's raising your blood pressure because it's vasoconstricting your arteries. So if we use beta blockers, we block that adrenaline and we relax the arteries, and your blood pressure will come down. The other thing about beta blockers, which is really a great drug, is if let's say we have somebody whose rhythm, their electricity part of their heart, is firing too fast. So we say anything between 60 and 100 is normal, but some rhythms you're up into the 120s, 130s, 140s, and your heart can't pump out blood fast enough. So it really takes a toll on the heart long term. Beta blockers, while they're blocking that fight or flight drug, that adrenaline, reduces your heart rate. It will slow and strengthen your heart rate, so your heart will function more effectively. So these drugs are great. Now, if you think about the beta blockers and we're slowing your heart rate down, we do not want to give you beta blockers if you're on a treadmill and we're trying to get your heart rate up to that 85% of target. Because if you take your beta blocker in the morning, we're never going to get you there, because we blocked the ability of that heart to the arteries to be constricted. We want them to constrict while you're exercising to try to get more blood to the heart. We want them to constrict to get your heart rate up. So your whoever's scheduling your treadmill test, stress test, will ask you to hold your beta blockers, and that's why we're holding them. All right, so probably, I don't know when the ACE inhibitors and the ARBs came out. I want to say maybe 20 years ago, but I'd have to look at that. So the ACE inhibitors really work on this renin-angiotensin system. It's complex. It's kicked off by the adrenal glands. It works with the kidneys. And what it does for ACE inhibitors is there's a hormone called angiotensin 2, and normally it circulates in the blood. So it affects other vessels other than just your heart arteries. And so if we know you have hypertension, and we know that angiotensin 2 is circulating in your blood naturally, we give you an ACE inhibitor, which are the prils, so like lisinopril or captopril, then that is going to block that hormone, that angiotensin 2, and relax those arteries again. Same thing with with the ACE inhibitors, with angiotensin 2 receptor blockers. It's that same, we're working with aldosterone in the angiotensin 2 receptors. This is like losartan. And a lot of people are on this drug. The great thing about the angiotensin 2 receptor blockers, because aldosterone is made by the adrenal glands and the kidneys, we found that they help diabetic patients. The ACE inhibitors and the angiotensin 2 receptors because diabetes will attack those arteries by the kidneys and other parts of that renin-angiotensin system. So these are excellent drugs, not only to help with, excuse me, blood pressure, but also to help people with their renal function. So we like to start out now with ACE inhibitors or angiotensin II receptors. So in summary of these medications, we talked about some of the hormones. We've talked about needing to block those hormones. But the biggest question that I get is, why can't I just take one of these? Why do I have to take more than one? Well, the answer is they all work differently on a different hormone or a different channel that we're trying to block. So we may be just fine taking one of them for, 2 or 3 years or 5 years. But then as we get older and our organs get older and our arteries get older, we may need to add a second one, because now we're going to work on a different hormone, or we're going to block those calcium. We're going to block that calcium. So typically we will start in that stage 1 hypertension. We start you on one of these drugs. Again, usually the prils or the sartans, because they're a better drug. Sometimes the lows, but we're seeing more prils and sartans, especially with renal disease. And we see how you do for a while. And if it works, great. We have you monitor your blood pressure at home, or you come in and get your blood pressure. But at some point, that drug is not going to be enough. So if you all of a sudden kick in and start doing all those lifestyle management pieces, that drug may be enough for quite a while. But if we don't do them together, at some point, most likely you will end up on another one of these particular drugs. All right, so I'm just going to do a summary here about lifestyle and medications, and this is how Dr. Kaji explains it, and then we'll open it up for questions. So again, my patients say, well, can I just do lifestyle management? Why do I have to exercise? Why do I have to watch my salt? Can I just go on a pill? It'll make me feel better. And it's easy. All I have to do is take a pill. So how Dr. Kaji describes it says, one boxer is your heart. The other boxer is lifestyle management and medications. So if you imagine, let's say lifestyle management and medications, let's say we take this lifestyle management arm and we tie that behind your back. Now, all we're going to do now is just give you medications. So this boxer has one arm to fight and your heart has two. So your heart's going to win. It's going to wear out. You're going to have hypertension. It's going to have to work harder, and it's going to wear out way before it's time. Same thing. If we tie this medication hand behind your arm, behind your back, and again, your heart is going to come at you with all of its might and of what it needs to do to function. And all you're committed to is lifestyle management, but we cannot get your blood pressure down or your cholesterol down where it needs to be. Your heart's going to win. It's going to wear out. You're going to have complications from plaque, maybe a stroke or a heart attack. If you can't lose weight, just using this arm of the lifestyle management, you're putting your heart under stress. Or if you're not treating that sleep apnea or snoring, your heart's going to win. It's going to win for a very short period of time, and then it's going to get tired. And that's when you're going to start to see the complications of heart disease. So with that, I thank you for your time, and I will open it up for questions.
Okay, Nick, can we go back and ask a question on cholesterol?
Sure. Hold on a minute. What is this on the Entresto and Jardiance question? Nope, way up here. I have a question. Community says, thank you. I have one that says, what is the category for medication thiazide? So these are thiazide, they're called thiazide medications, and they actually are diuretics. And so that's a different category. I did not choose to talk about that one tonight. We use hydrochlorothiazide in combination with typically a beta blocker or an ACE or an ARB when people are up into that 140 stage 1, 150 stage 2, that the guidelines say you need to start people on dual therapy. So we'll start people on thiazide diuretics because they don't deplete your potassium, as well as one of those other hormone blocking agents. Again, that is another one. Also, the diltiazem is another drug. I just chose not to talk about those tonight. Hydrochlorothiazide is a diuretic. Yes. My 36-year-old daughter just had a viral myocarditis and was in the hospital for 5 days. After she left, her heart rate went down to 40, what caused a low heartbeat. The medicine was adjusted, but her heart rate is still low. She does smoke. I don't have enough information to probably answer this. The inflammatory part of myocarditis could be causing some of that low heart rate, but I don't know what medication she's on. So 40 is very low. People do not function well with a heart rate of 40. They don't feel good. They're very sleepy. They get lightheaded when they stand up. So without knowing if the myocarditis caused the heart rate or if the medication was causing the heart rate, it sounds like the medications were, then this would mean that we still need to continue probably to adjust whatever medications they have her on. As the myocarditis gets better and her heart recovers, which will take some time, we will probably see, I don't know that she'll never need medication, but she probably may need less of it. So I don't know if that answers the questions or not. Smoking is not related to low blood pressure, but it certainly will elevate her blood pressure, puts her stress under puts her heart under stress, but more importantly causes she's laying down plaque to clog her arteries. So she'll either could end up with a heart attack or stroke at a very young age. All right. Where do Entresto and Jardiance fit in the medications? Again, I didn't choose not to talk to these are the new SGLT2 inhibitors, and we use this a lot with heart failure. These were medications that were really, the research was done on diabetic patients, because what happens when you take them is you basically pee out sugar, which lowers your blood sugar. So we see improvement with people's diabetes. What we also saw was that it was effective for people who have heart failure because it made the heart pump more effectively. It makes that muscle work more effectively. That, again, very basic understanding of Entresto and Jardiance, but that's really people can't qualify for it unless they have some sort of congestive heart failure and they're very, very expensive. So I don't know. I'm hoping that answers the question on that. If not, we'll go back. How large, did I miss one? How large does a role heredity play as compared to potential life changes? A very small part of what we see is hereditary. There is a hereditary component, so especially in aneurysms and in hypertension. So I can give you my personal experience. My grandpa on my mom's side died of a massive heart attack, and he was like 50. My mom has significant hypertension and had her first open heart at the age of 60. And I was started on antihypertensives when I was 39 after my second son. And I weighed then about 130 pounds. I worked out. I did all of the right things. But the genetic part of that hereditary was really what was forcing my heart muscle or my blood pressure up. So I've been on multiple medications over the years, but a lot of that genetic piece, I was just, that was my mother's gift to me. So really, yes, hereditary plays a part, but lifestyle plays a larger part in trying to keep our heart into a healthy, functioning kind of phase. So thank you. That's a great question. Contrary to high cholesterol, can low cholesterol below 120 cause problems? No, not that I'm aware of. I have talked to Dr. Kaji about this because we do see some very low cholesterols, and it really doesn't cause much trouble at all. We see low density lipoproteins. That's the bad cholesterol. We want to keep that below 100. We've seen people as low as 8. And as long as it's below 100, again, I would need to dig into the research, but I did specifically ask him about this. It does not cause significant problems at all.